This slide's presentation will cover management for several of the different CVA movement system diagnoses that we've seen before. I like using this strategy because you can identify the movement system diagnoses via a task analysis or the basic patient examination findings. And then you can think about how to manage this patient by categorizing them into these groups. So as we've talked about before, there are some key ingredients for designing CVA interventions, and that is to take advantage of all of the neuroplasticity rules that we've talked about before. Use it or lose it, task-specific practice, salience matters, expectation matters, all of the things that we've talked about. Use it and improve it. One more thing that I wanted to add on to all of this information is that starting intensive therapy too early does not have very good outcomes. For the most part, you should wait about 36 hours before starting intensive therapy with patients after they've had any sort of brain injury. Things to consider during your treatment. And again, we've talked about all these things before. What stage of motor control? Are you working in stability, mobility, or dynamic postural control? What stage of motor learning is your patient in? Are they cognitive, associative, autonomous? You want to consider the kind of practice schedule, whether it's going to be blocked versus random, how much feedback you're going to give, when to monitor or manipulate environmental diversity. And in addition, with patients post-CVA, as we've talked about, you also have to consider their limitations. Do they have hemiparesis? Is there a field cut involved? Do they have neglect or some sort of perceptual deficit of midline? Do they push? Sensory loss, aphasia, as well as apraxia. And then finally, you want to consider the use of any equipment and also the use of your hands. Remember, where you touch this patient really makes a difference as far as what muscles are going to fire, as well as the fact that you want to be able to guide normal movement patterns as opposed to just having them compensate for being able to do a task. Finally, very important, safety. Keep yourself safe, help your assistive personnel stay safe, and finally, always make sure that your patients stay safe. First, movement system diagnoses. Hopefully this is one we've hit pretty hard so far, and that's going to be your force production deficit. By definition, and from the Sheets et al. Article, this is a patient who has less than 3 to 4 out of 5 muscle strength. And when you look at their task analysis, they're going to have difficulty with sit to stand. Typically, their sit to stand, if they're relatively weak, is going to require some sort of assistance or accommodation. As well as the fact that when they try to walk, they might need manual assistance or some sort of assistive device to help them maintain their upright posture. Thinking about interventions for this patient population, if they lack trunk strength, this is the place to start. Okay, we started this earlier on in the semester where you're going to promote upright posture. Here's a link here to the FEL chapter 35, talking about a lot of the techniques that we've demonstrated previously. In general, the patient might require manual facilitation for lumbar and thoracic extension. They might need to have abdominal contraction controlled for them to maintain a neutral pelvis. Okay, essentially, you want to initiate and possibly will have to maintain this for the patient until their trunk muscles start to fire. If they don't need your help, if they don't need you to maintain and they don't need you to initiate, then it's perfectly okay to take your hands off. And one good way to get their weaker side stronger is to have that person perform some reaching activities and sitting to help that trunk remember how to fire properly. Okay, once you get the trunk to fire, then it's a good idea to start activating the hip and knee extensors, and this is going to be in preparation for standing. Okay, remember we did this by demonstrating some scooting activities where the person's going to scoot to their right side and left side, where you're facilitating maybe hip and knee extensors to fire at the appropriate times, and also incorporating some upper extremity weight bearing. You can progress this to a partial sit to stand, having the patient reach forward with their unaffected hand, maybe starting with a higher mat surface and then progressing it to a lower mat surface to help with that hip and knee extensor strength. Okay, according to the Sheets et al. Article, here's some low-level patient intervention ideas. And again, there's a link here to Appendix 3 from this article. And they like to start with functional resistance training. I agree 100%. Keep it functional as much as possible. Consider doing pre-gait activities. Always incorporate the upper extremity as much as possible and make the activities challenging. Think moderate, but attainable. Okay, you can progress to walking. Okay, we'll work on walking here coming up pretty soon, where we'll teach you how to wrap the ankle into dorsiflexion to maintain dorsiflexion during swing phase of gait. When you're doing walking, you might have to be in a seated position where you're in a good position to guard or block that knee from collapsing during stance phase. And overall, if you really want that patient to get back to the way they were walking before they had their stroke, you really need to progress to walking with no upper extremity support, if at all possible. Another idea they have is stair climbing. Okay, you might need to assist with hip and knee extension during stance phase on that affected side in the beginning, and you can start with both hands on the rails. Again, that means that you're using the affected upper extremity as much as possible to help support balance. And then you can progress to only using the affected upper extremity when it starts to regain a little bit of strength, and that will promote forced use and help get that upper extremity back. And then finally, you want to try some sit to stands, and you can start from an elevated surface and then progress to a lower level surface. And essentially, you might have to provide some facilitation for the quads. You can recommend that the patient hold their hands clasped in front of them so that they don't need that upper extremity support, and just go for quality repetitions. Again, according to the Sheets et al. Article, this patient can progress, or if you have a patient who's at a little bit higher level, you can also use these as appropriate interventions. In this article, they were talking about using stairs, going 1 to 3 flights at a time with increased speeds and increased step heights. You can also try treadmill walking. Okay, the treadmill walking can be at various grades, so that as you increase the grade, you're not only promoting foot dorsiflexion, but you're also increasing the intensity of the activity. And finally, you can progress this to overground running. This might require standby assist to help prevent a fall. A good strengthening exercise for the core is going to be any kind of plank. I like using planks overall, whether they're going to be front-held planks, back-held planks, or side planks, especially using the hemiplegic upper extremity side to perform these planks. And if the patient can't hold it for even more than 10 seconds, have them go up and down and slowly learn to hold in that position to regain their core strength. Remember, core strength is going to be huge for patient balance. And then finally, you can progress them to strength training with weights. Consider squats and deadlifts and lunges, or anything that you can that are whole body exercises. There's a nice article that I found, the Kim et al. Article from 2020, and it's a general guideline for exercise prescription post-stroke. Okay, if somebody's had a mild or moderate stroke, these are the recommendations. General aerobic exercise is pretty similar to what you have seen before. Again, you want moderate intensity, 3 to 5 days a week, gradually increase from 20 to 40 minutes over time. And these can be progressed to advanced aerobic exercise prescription, which can be 5 to 7 days per week and at about 60 minutes at a shot. And here, you want to consider the intensity of the exercise. For general, it's 40 to 59% of heart rate reserve, okay, which is going to be a 120 to 13 on a 20-point RPE scale. So think heart rate about 120 to 130-ish. Whereas the advanced aerobic exercise is anywhere from 60 to 80% heart rate reserve. This is moving pretty good with an RPE of 14 to 16 or a heart rate of 140 to 160 on a 20-point RPE scale. Then finally, when you're prescribing general resistance exercise, similar to what we've seen before, it's going to be 2 to 3 days a week, anywhere from 1 to 3 sets. Start out with 1 set, and as the person gains experience, increase the number of sets. They're recommending 10 to 15 repetitions of each exercise, which puts it in kind of the endurance training phase, and they're recommending to do 8 to 10 exercises. Again, whole body exercises are going to be more important than the assistive exercises. Resistance is going to be, or the intensity is going to be starting out at 30 to 50% of 1 rep max, progressing all the way up to 50 to 80% 1 rep max. Okay, you can, it's really important to increase strength is to challenge the patient. So if you truly want to get them stronger, consider the amount of weight that you're using with this patient population. Again, to increase strength, you should start with a reasonable duration or frequency and intensity and be within the tolerance of the person, and then slowly progress them over time. As far as resistance exercises are concerned, you want to give them a rest period of at least 2 to 4 minutes because you remember you're trying to increase their strength. Strength training, you want at least 1 day between strength training sessions, and ideally for same muscle groups, I'd prefer 2. And you might want to consider alternating aerobic and resistance training, but know that they can be performed on the same day. And as always, we want to make sure that we're monitoring patient vitals to make sure that they're safe before exercise, during, and after exercise. Moving on to another movement system diagnosis. This is another one we've talked about a bunch, and that's the fractionated movement deficit. Okay, we've talked previously that upper motor neuron may progress to hypertonicity or spasticity post-stroke. And you should know that only about 20 to 40% of patients post-stroke actually progress to hypertonicity. And we talked about the fractionated movement deficit being the fact that the person is unable to move one joint independent of another. And ways that you can see this is a task analysis, particularly something like sit to stand. It's going to be difficult to dissociate the movement of one joint from the other, so that the patient usually has their hypertonic lower extremity sticking out because they can't adequately bend it enough. Gait, you're going to see things like hip hiking, vaulting, circumduction, especially during the swing phase of the affected extremity. And you're going to notice a considerable stiffness in the hip, knee, or ankle during swing phase. The Sheets et al. Article has an Appendix 4 that talks about decent interventions for patients with a fractionated movement deficit. In my experience, I've not been able to do anything that's going to affect hypertonicity in this patient population in the long run. Actively using the musculature or increasing the strength of the antagonist is going to be helpful, but it's not a long-lasting intervention. Okay, in this article, they're talking about postural stability by doing things like walking with and without an assistive device, think a straight cane or a quad cane, possibly stepping over objects to start to get some possible fractionated movement, and also balance control when working with a leg that's super stiff. Also, another good idea is going to be retrieving objects to the floor from the floor, and this is going to be working on active flexion of that lower extremity, which was always so stiff in the extension synergy. Functional training ideas, similar to others, are going to be sit to stand tasks, walking up and down steps, even open and closing doors while walking. Because remember, if that person is using an assist device like a cane, when they pick up the cane and they have to use their unaffected extremity to open a door, they're going to start to lose their balance. Okay, and then to get them out of the habit of using something like a cane, you might want to have them carry objects in their unaffected hand too, and again, work on their balance, because these are very functional activities. The picture shows here on the right-hand side of the slide, increasing a patient's walking endurance and speed using bodyweight supported treadmill training, and this is something that we will practice later on in the semester during lab. Another movement system diagnosis that we're going to talk about today is a perceptual deficit. Perceptual deficit is pusher syndrome. Okay, the person does not have an accurate indication of midline. Their verticality is off toward their affected side. And you can clearly see this in a task analysis, whether it's going to be sitting, sit to stand, standing, or walking. They're going to shift their center of mass way to the affected side and posteriorly. And they're also going to resist correction. Okay, when you try and push them back to that position, they're going to resist that pushing. So essentially, you should never push a pusher. The Sheets et al. Article has an Appendix 5 where they talk about some intervention ideas with this patient population. And the first thing that's really important is to increase awareness of their perceptual deficit. That person has no idea at all that their midline is off. So you can use some environmental prompts such as a mirror, okay, or you can use a wall. You can have them leaning on a mat surface, and you see in the picture here on the right-hand side of the slide that person is leaning on their unaffected arm. Okay, that helps that person feel safe because they truly feel like they're going to fall over when they're leaning upright and vertical. You can also have a wall on their unaffected side so that they can lean on the wall because they know that wall isn't going to move, so they feel safe. They feel like they're not going to fall over in that direction. And you could also have a person on that unaffected side, and they can start leaning on that person to help feel safe. And then you can ask, are you leaning on me? And I mean, make them realize, especially if you're on their unaffected side, if they're on their affected side, if you ask if they're leaning on you, they're going to become aware that, yeah, they're kind of leaning over in that direction and they need to go move toward the other side. When working with a patient that pushes, you should be aware of the fact that they might push in sitting, they might push in standing, and they might push in walking, or they might push in all three. You really don't know until you try. But realize that if a person is pushing in sitting, and then you kind of get their midline back again, when you stand them up, their midline is going to be gone. So you have to work on actively getting them to move toward their stronger side in a sitting position, a standing position, and again, a walking position. And I have some ideas that I've used in the past with patients that push. These are things that we're going to do in lab coming up here real soon. The good news is that for patients that push, the pushing or their perception of midline usually gets better within 3 to 6 months with appropriate therapy. But it is a challenging patient population to work with, especially if they have any other deficits that go along with the pushing. Okay, another movement system diagnosis, and this is just a movement pattern coordination deficit in patients post-stroke. This would be a patient with a very mild stroke. Their strength is fairly good, but they're going to have difficulty with the speed and timing of movements. And a standard test that you can use to identify this problem is just a foot tapping test. This dysdiadochokinesia that we've talked about previously, looking at coordination. Okay, in a task analysis, their sit to stand is going to be fairly good. They're unlikely to require physical assistance. And with the reach and grasp, they might have difficulty controlling their force and like how they're reaching. But know that this kind of problem will improve with repetition, instruction, and practice. Okay, the more they do it, the better they get at it. So this is something that can definitely get better. As far as movement pattern coordination deficit intervention ideas, you can use any of the higher level interventions for force production deficit that I've mentioned previously. Other things that I've used with this patient population is going to be like the We Fit. Any of the balance games work really well to help them get fully back to themselves. Any kind of high level yoga poses that you may have been exposed to. Another favorite is jumping jacks, and that's what I have in the picture on the right-hand side of the slide. If the patient doesn't feel safe using their upper extremities and lower extremities at the same time, you can have them stand in front of, say, parallel bars, holding on with both hands to the parallel bars, and then just working on bilateral lower extremity abduction, kind of like a lower half jumping jack by itself. And you'd be surprised at how difficult this will be for the person, because that affected side just doesn't have the speed and timing of the unaffected side, and it really comes through with jumping jacks. Other high-level activities would be throwing and catching a basketball, dribbling a basketball. You can start with both hands dribbling and then progress to just the affected hand dribbling in a gym. You can have the person kick a soccer ball against the wall with both the unaffected and the affected side. Okay, even the kicking might be a little bit off, but even standing on the affected side is going to help promote balance with that person. Okay, and then you can progress that to keeping the ball in continuous motion while you're kicking it against the wall, and then finally dribbling a soccer ball like a soccer player would be between their feet, just back and forth, and then you can progress that if you have the opportunity to keeping the ball up in the air with both lower extremities. Very high level activity. And finally, another idea, if the patient is able, would be jumping rope. And all of these are very high level activities to get back that speed and timing and coordination of movement that's required for everyday activities. And finally, this isn't a movement system diagnosis, but it's something that you're going to see in the clinic. And here are some intervention ideas for patients that present with neglect. Okay, with patients that have neglect, the most important thing you can do is force that patient to look left. Okay, so you want to position the patient so that the door is to their left. So you might have them in the room, and if you're working in a hospital setting, they might be facing a closed or pull the blinds on the window. They're looking toward their right side, and the door's on the left. That means any activity is going to entice them to turn their head and look in that direction. Okay, you also want to position the patient so that the TV is to the left. All right, turn it on, make the sound happen so that they're, again, enticed to turn and look to their left side. You want to also educate the family on the importance of staying on the patient's left side. A lot of family members might think it's rude to stand on the person's left side when the person is always looking to the right. You want to tell them the importance of forcing that person to look left. And having said that, you want to be standing on the person's left side as much as possible when you're working with this patient. If they have a higher level of neglect and really have difficulty even getting to midline, then you want to start out at midline and force that person to direct their attention toward you. You want to incorporate the left upper extremity in all activities as much as possible, especially sometimes with severe neglect. That person might not even realize that the left upper extremity is theirs. The more that you have them attend to it and pay attention to it, the better it's going to get. If that person is ambulatory, you definitely want to have them walking around the gym following colored tiles. So, for example, if you think about going, let's say, counterclockwise around a big a square or a round gym, or that square, because you get to that corner square, and then if you don't look left, you don't see the colored tiles that are surrounding the gym anymore, right? They kind of disappear. But if you have the person turn their head and follow the tiles, then they get in the habit of looking left if you're always making turns to the left. Another popular activity is to plant some cones, some brightly colored cones around the gym. And when you're walking with the patient, make sure that the cones are situated on the patient's left side and have the patient find the cones. Another challenging intervention is going to be to have the patient drive their wheelchair through a doorway. You would be surprised at the number of wheelchair divots there are in door frames from patients who have had neglect. And finally, even walking. When you're walking with this patient population, if you're walking with them through a doorway, they very well might not give you enough space to get through the door as well. So you want to cue them to look to see if they're going to run you into the wall when you're guarding them and walking them.